Hi everyone, my name is Brittany Mannering, and I'm a nursing student at Winston-Salem State University. Today I will be conducting a thoracic and lung assessment. This is for my video final for nursing class 2501, Assessing Health Alterations. Here I have with me Mr. Dustin Key. He has agreed to be my patient. Mr. Key, do you mind if this assessment is videotaped and posted on YouTube for educational purposes?
No, I don't.
Okay, great. Now that we have Mr. Key's verbal consent, I will first begin by asking a few questions. Can you please state your name and date of birth for me?
My name is Dustin Key. My date of birth is February 19th, 1988.
Okay, great. And can you tell me what type of building we're in today?
We're in a house.
Okay. Can you tell me what year it is?
2013.
Okay. And can you tell me what town we're in?
Pilot Mountain, North Carolina.
Great. The patient is alert and oriented to person, place, and time. Alright. Have you had any recent shortness of breath?
No, ma'am.
Any persistent cough?
No, ma'am.
Any pain or difficulty with breathing?
No, ma'am.
Okay. Are you a smoker?
Of course not.
Okay. Any past history of breathing trouble or lung disease?
No, ma'am.
Okay, great. Have you been exposed to any environmental toxins or pollutions that could affect your breathing?
No, I haven't.
Okay. Have you had your pneumonia and flu vaccine?
Yes, I have.
Okay, great. When was your last TB test?
I think last year.
Okay, good. Have you experienced any frequent or recurring colds?
No, ma'am.
Okay, great. Now that I'm done with questioning, I will just begin by inspecting the anterior chest. I'm looking at the thoracic cage and the chest wall to make sure it is symmetrical. I'm also looking at the ribs, and they are sloping downward. And the inner spaces are symmetrical in the ribs. I'm also looking at Mr. Key's facial expressions. I'm looking to make sure that he appears relaxed and appropriate. If Mr. Key had COPD, his face may appear tense or tired. Also, with cerebral hypoxia, you may note that your patient could be drowsy, anxious, restless, or irritable. Mr. Key appears relaxed and appropriate, so his facial expressions are normal. I'm also going to be checking his skin color and his nail color. Let's see. Alright, I don't see any cyanosis, pallor, or clubbing. Clubbing can often be seen in patients with chronic respiratory disease. As I inspect, I'm also noting the rate and rhythm of respirations. I'm noting that the patient's breathing appears relaxed and effortless. The breathing pattern is regular, even, and non-labored. There is no distress noted. Next, I will begin to palpate. Mr. Key, this means I'll be touching you. Is this okay?
Yes, ma'am.
Okay. First, I'm just going to start by feeling. I'm checking for any pain or tenderness. Are you experiencing any pain or tenderness as I touch?
No.
Okay. I'm also looking for any mass or lesions, which I do not feel any. Next, I will check the chest expansion. I will place my hands in the costal margins with my thumbs pointing towards the xiphoid process. Can you please take a deep breath? Okay, great. The chest expansion is smooth and symmetrical. There are no lags noted in the chest expansion. If you noted a lag, the patient may have atelectasis or pneumonia. I'm next going to assess tactile fremitus. What this is a palpable vibration that is best felt using the ball of the fingers. Mr. Key, each time I place my hand, can you please repeat the numbers 99?
Sure.
Okay.
99. 99. 99. 99. 99. 99. 99. 99. 99. 99. 99. 99.
Okay, great. Also, if you're ever assessing a female and you're checking for tactile fremitus, just remember not to check over the breast tissues. This can often dampen the sound. Next, I will begin percussion. As I begin percussion, I want to compare each side to one another, making sure that I hear the same thing on one side as the other. Okay, great. In healthy lung tissue, the sound should be clear and hollow. That's what we heard today. If you hear a dull, soft, or muffled sound, this can signal abnormal density in the lungs. Next, I will begin auscultating the anterior chest. Mr. Key, this means I'll be listening to your lungs. Each time I place my stethoscope, can you please take a deep breath for me?
Sure.
If you begin to feel dizzy or lightheaded, please let me know. We can stop and take a break, okay? Okay, good. There are no adventitious breath sounds heard. The lungs are clear bilaterally. It is best when assessing your patient not to listen over top of clothing. This can interfere with the sounds, but for this purpose, we will keep our patient clothed. And also remember to avoid any other rib bones, okay? Next, we are going to go to the posterior side. I'm going to have you turn around for me, Mr. Key. Okay. I will begin first with inspecting. As I look at the posterior side, I'm checking the neck muscles. I'm looking at the trapeze muscle also, and I'm noting that the muscles are appropriate for age. I'm also inspecting for any skeletal deformities like scoliosis or kyphosis, which none of these are noted. I'm also looking at the patient's position. I'm looking at his posture to make sure that it is relaxed and that he is able to support his own weight comfortably. As I begin to palpate the posterior chest, I'm checking for any pain or tenderness. Do you have any pain or tenderness?
No, ma'am.
Okay. I'm also feeling for any mass or lesions, and I do not feel any. I'm next going to check for chest wall expansion again. I'm going to place my hands on the chest wall, my thumb level at the T9. You can also place it at the T10 level. Can you please take a deep breath? Okay, great. The chest wall expansion is smooth and symmetrical. Unequal chest expansion can occur in patients with marked atelectasis, lobar pneumonia, pleural effusions, or thoracic trauma. I will next check for tactile fremitus on the posterior side. Mr. Key, again, as I place my hand on you, can you please repeat the numbers 99?
Yes. 99. 99. 99. 99. 99. 99. 99. 99. 99. 99. 99. 99. 99. 99. 99. 99.
Okay, good. The vibration should feel the same in each corresponding area on each side. Again, remember to use the ball of your fingers when checking for tactile fremitus. Next, I'm going to begin percussion of the posterior side. Okay, good. When percussing, there should be a low-pitched, clear, hollow sound. This is what we noted today. Next, I will begin to auscultate the posterior side. Mr. Key, I'll be listening to your lungs again. Each time I place my stethoscope, can you please take a deep breath?
Sure.
Okay, good. Breath sounds again are clear bilaterally. If there were any adventitious sounds, some of the common ones are wheezes, crackles, ronchi, or a lot of times in the elderly, their breath sounds may be diminished. I'm next going to determine the quality of voice sounds. Lifting voice sounds is not done routinely unless you suspect lung disease. In this case, we would just check them for educational purposes. I'll do the same thing as earlier when checking for tactile phragmitis. This time, however, I'll listen with my stethoscope. Mr. Key, each time I place my stethoscope on you, can you please repeat the numbers 99?
Sure I can.
Okay.
99. 99. 99. 99. 99. 99. 99. 99. 99. 99. 99. 99. 99. 99.
Okay, good. I can hear the sound, however, I cannot distinguish it exactly what Mr. Key is saying. The voice transmission is soft and muffled. This is normal. This will conclude our assessment. There are no alterations noted in Mr. Key's lungs or thoracics. Thank you, Mr. Key, for your participation and cooperation.
You're welcome.
Again, my name is Brittany Mannering, and you just seen me complete the thorax and lung assessment for Nursing 2501, Assessing Health Alterations.